You're listening to Healthy Aging on Dr. Radio, Sirius XM 81.
Welcome back to the Healthy Aging Show. This is Dr. Michael Perskin, and we just had a great conversation on sleep. We're going to really just do a 180 or different direction, and we're going to now speak about post-acute care. And I'm very pleased to have on Mary Fran Thaler, who's a vice president at the Hebrew Home in Riverdale. She's a certified physical therapist, and we're going to talk a little bit about, I guess, what's commonly called subacute rehab. So maybe, Mary Fran, you could tell us a little bit about what that means and what group of patients does this apply to generally? What are we talking about?
So if an individual finds themselves in an acute care hospital.
Like for pneumonia or a heart attack?
Pneumonia, heart attack, stroke, a fall with a fracture, a motor vehicle accident, and they find that after the course in acute care, they are not ready to go home, whether it's physical or support in the home, then it is advisable for the individual to consider going for post-acute care, and one of the places that you can receive it is in a subacute unit, and it can be located in a skilled nursing facility.
Some are not, right? But many, and at least in our area here in New York, they generally seem to be affiliated with a few big exceptions, which are more acute rehab.
Right. So post-acute services is really an array of services, and it's really dependent upon the needs of the individual. So you could have a post-acute service delivered in an inpatient rehabilitation hospital, or you can have post-acute services subacute delivered in a skilled nursing facility. But an additional post-acute care area is home health care, which is also post-acute. Anything after an acute hospital stay, based on your specific individualized needs, it would determine which location you would go.
And some of that is teed up because, in fact, there are some rules from CMS, from Medicare about this, right?
Yes, and right now the focus for Medicare is to ensure that the optimal outcomes from a functional level are achieved in the shortest possible time, because there would be associated cost savings with that.
But what I mean is, if someone goes to an emergency room with a sprained ankle, they cannot, under Medicare's rules, get admitted to what we're talking about here.
That's correct.
Whereas if they actually fractured their ankle and they had certain needs, let's say they needed a surgery on their ankle, and then they really weren't able to be safe at home,
correct,
they would then qualify, and I think you have to have a 3-night stay, is that right?
Right. Medicare and CMS continues to require a 3-night hospital stay prior to admission to a skilled nursing facility for subacute care. If you are admitted to the hospital under a private payer or a managed care company, they have different guidelines.
But a lot of times they sort of eventually tee up off the Medicare. Although in this case, it almost doesn't make sense. But those of us who do live this day in, day out, right? Because don't forget, I have a clinical practice in internal medicine and geriatrics. Sometimes you really need to understand those rules, and people get really frustrated, right? Because they sometimes the rules don't really make sense for an individual.
Correct. And one of the other rules from the government, from Medicare, that is hard for consumers to understand is that they will be told that you can receive 100 days of therapy if you are admitted to a skilled nursing facility for subacute care. And the key factor is you must qualify to receive those 100 days of services. And the person who qualifies you is the licensed professional. So a licensed physical therapist would qualify you, along with the clinical team, obviously including physicians and other therapy professionals would qualify you for that. So the average length of stay of someone who is covered by Medicare in a subacute facility is rarely 100 days.
Right, and I think that's a key word, that qualified, and I think it's very important to explain to folks, maybe give an example on Mary Fran, because it's not like getting your parking validated.
Correct.
You don't just get it signed for showing up.
So that an individual who's admitted to a skilled nursing facility for subacute services would need to, on a daily basis, demonstrate the motivation to participate actively in the therapy and treatment program and be determined to show progress in their ability, whether it's cognitive or functional, that they are demonstrating improvement in function in a predictable period of time.
Right, so a good example might be, let's say someone breaks their hip. So an older person falls down, breaks their hip, and they get they have a acetabular fracture, and they get a hemiarthroplasty. So they get a particular type of fix on their hip.
Right.
And then, of course, maybe they're maybe they have high blood pressure, maybe they have a little heart disease, and they're a little frail. It's not particularly complicated, but they basically can't get out of bed and get to the bathroom after a few days in the hospital. Not an uncommon situation.
Right, and if they come into a skilled nursing facility and for the first 3 days they refuse to get out of bed because they just don't want to deal with the situation that they're in, Medicare would say that you are no longer qualified to remain here because you're not actively participating in the plan of care. But if we go forward and say the therapist comes into the room, the individual is trying hard to get out of bed, is working with the clinical team and trying to get up and walk, and if they continue to demonstrate that willingness to participate, the government will allow us to continue to try to improve your function so you can go home.
Right, so this is why I get the call from typically the daughter who says, they want to kick my mom out because she's in too much pain to go to therapy or something.
But that's where the clinical team and the subacute environment have to work together and coordinate pain medication administration a half hour prior to the therapy, that we're all going in the same direction, achieving the outcomes and goals stipulated by the patient.
Right, and now again, the outcomes and goals is sort of a menu of those things of what, right? They're not going to fly a kite. They're going to have to be able to get out and go to the bathroom or walk to the, to the bus stop from their home, things like that are very specific.
And we work with the patient and their family and their caregivers in the community to identify the requirements for them to safely go to their home. So if they had a flight walk-up apartment in the city, we would need to make sure that they can adequately walk up 4 flights of stairs prior to their discharge home.
Right, and again, those are kind of the individual nuances that are tough for folks to understand, and sometimes they need to articulate that. So, Mary Fran, what we're going to do is we're going to invite our listeners to call in if they have questions. This is Dr. Michael Perskin. We're here on the Healthy Aging Show on Sirius XM 81. I am speaking with Mary Fran Thaler, who is administrator. She's a vice president at the Hebrew Home in Riverdale, as well as being a certified physical therapist. We're talking about post-acute care, about what people call subacute rehab. And you can give us a call if you have a question. Maybe you have been in an accident, or one of your parents had a problem, and you want to share a story or ask a question. You can give us a call here on the Healthy Aging Show at 877-NYU-DOCS. That's 877-698-3627. You may also send an email to docs@SiriusXM.com. Now, Mary Fran, so the benefits to people then are really just the gains in the functional outcomes?
Yes, that is true. I do want to point out that many times individuals who've been involved in an accident or had a stroke and are in an acute care hospital, what they want to do is go home as quickly as possible.
Right.
And what they need to remember is to take advantage of the benefits that they have based on their insurance carriers. So, for example, a Medicare beneficiary should take advantage of the fact that they can go into a subacute facility and receive 5 to 6 days of rehabilitation therapy every day so that they can achieve those outcomes and their own goals in a shorter amount of time. Whereas if someone insists on going home after the hospitalization, they will receive home health agency services, but the intensity of service delivery in the home is not the same as it would be in a skilled nursing facility.
Right, because they might come, let's say, 3 times a week.
Correct.
Although I think that's going to also be in motion now, right?
Mm-hmm.
So I think that's going to be some of the changes that we see in healthcare delivery, because we have pretty broad lanes that we put people in, and when you deal with people on a case-by-case basis, there's really many more lanes than we kind of have right now. It's either home with services or subacute or occasionally acute inpatient rehab, so higher level.
Yes.
But probably there's some more nuances there.
Well, for the inpatient acute rehabilitation facility, you have to be able to tolerate up to 3 hours of therapy a day in order to be considered for admission. Whereas in a skilled nursing facility, we do provide up to 3 hours of therapy a day, but if you can only tolerate 30 minutes, then you can remain in a skilled nursing facility and receive those 30 minutes.
And you would get it 5 or 6 days a week, you said?
Certainly.
All right, so let's read an email from Helen, who writes, "My mother, age 76, fell and broke her hip a few weeks ago. She is absolutely refusing to do any of the physical therapy exercises that they are recommending. How can you convince someone that they are worth it when they're resistant?" I guess she means that the exercises are worth it.
I guess my first question for Helen would be, is your family member able to get up and walk? Oftentimes I've said to an individual, if you choose not to do these exercises, then just understand that you're also choosing to limit your ability to get up and walk. And if your motivation is to get up and walk, then these exercises are the building block to doing that. So I would take that type of an approach and also oftentimes family members don't listen to family members. It's really important that the physical therapist or the home care agency come in and reinforce it also.
And just reading this little vignette, to me as a physician, I would be very concerned that the patient has depression. 76 in 2013 isn't that old, but 76, breaking a hip, you could see how someone could be very depressed, not want to deal with that situation. And as you said a little earlier, Mary Fran, you need to be willing to do the therapy. And I think the phrase you used was deal with the reality of the situation. And maybe you can amplify that a little bit and make some additional comments.
I think that we have to give credence to the psychosocial, the emotional, the aspect of the fact that an individual had an accident which wasn't planned, who ends up in the hospital and requiring surgery, and the pain is excessive, and their lifestyle has changed completely. And we have to anticipate as a family unit or a caregiver unit the impact and be as supportive as we can to make your mom understand that at 76, if she puts her mind to it, she will achieve the goals that she wants. And the fact that there are exercises that will help her do it really needs to be reinforced. But the other thing you might consider is oftentimes there are aquatic or pool exercise classes that someone who suffered an orthopedic injury that involves a lot of pain, or if they've had arthritis in the legs, that the pool water exercise would make your mom feel younger in a sense because she'd feel more freely mobile with less pain. So you might want to look into local options for pool.
Sure. Yeah, and I think the other thing to consider for folks is, they sometimes get really frightened and they don't want to become a burden. And the other tool I use personally to motivate the patients is to help give them a vision about what they can do. I mean, it's fine to say, don't walk, and of course Helen didn't tell us much about the details of her mom's life, but presumably she's not working and doesn't have a young family. So sometimes this kind of a situation, an accident, as you say, no one planned it, and then it just happens, is devastating because it points out what is she trying to achieve. And what I've found in my experience has been if it turns out that one of the grandchildren is getting married in 3 months, there's a bigger motivating factor because they want to be in the wedding or see the wedding or whatever. And I find that kind of stuff really helps much more than telling them, well, you'll walk, because they need to feel purposeful.
And you have to have a goal outside of yourself. Absolutely. Yeah. I agree.
All right. Again, we are speaking with Mary Fran Thaler from the Hebrew Home. We're talking about post-acute care and what it means and some of the things that you're entitled to as a Medicare beneficiary or if you have commercial insurance. Here on the Healthy Aging Show, and you can give us a call if you have a question or comment by calling 877-NYU-DOCS. That's 877-698-3627. So, Mary Fran, here's another email from Jessica, and she writes, do you have any advice for handling the rehab schedule for an otherwise fit 79-year-old who has memory loss and dementia? She was hospitalized after a car accident. She wasn't driving and seems to otherwise be recovering well. But it's hard to have goals for someone who can't remember from day to day what the goals are. So, Jess, that's a good point. So there are some special considerations in folks with cognitive impairment. So, Mary Fran?
One of the strategies that I have used personally successfully with an individual who can read is to have cue cards or a series of cards that would direct the activities throughout the day, which would permit your family member to achieve success and to allow the caregiver to organize the day in a meaningful way. So creating very task-specific and not very complex cards to guide the activities throughout the day would be one recommendation I would have for you.
Yeah, is there going to be, cue cards seem great and I've seen them used, but, you'd think with all the stuff we have now, maybe you could talk a little bit about what you think's on the horizon in terms of, more gadgety things like iPads cueing people, things like that.
Technology has certainly created opportunities for us in healthcare, and there are often software systems that are also being used for cognitive fitness programs that we are also investigating through research at the Hebrew Home, so that the brain fitness idea, but getting back to your point of using an iPad or an Outlook calendar, which would give you the schedule of activities. You could also have reminders pop up. It just depends on how familiar your family member is with the technology, because what we've found is that the older adults sometimes has a hard time adjusting to the new technology if they haven't been familiar with it before.
Yeah, I think, and of course, every generation changes, right? So, as people age now, it's hard to imagine that someone who is now 65 is going to have the same relationship to that kind of technology in 10 years when they're 75 or 15.
Right. Now, we found in our subacute facility, where the average age is around 72, that many more people are coming in with their iPads and their smartphones. 100% of their children are coming in asking for Wi-Fi access, but we're seeing fewer people in their 80s familiar with it, but that's growing also significantly.
Right, and and a type of thing, the iPad is simple enough to turn on, so it's simple enough that you could have, a family member cue their relative by calling and saying, okay, now you're going to turn it on, and you sort of set it. Right.
And there are also apps available for purchase online that you can look to for structured solutions for someone with cognitive impairment.
Yeah. Well, having the visuals is so much better. I mean, I can just tell you for myself, when I've, just for little sports injuries and things, want to do stretches, it turns out, it's hard to follow the kind of static printed stick figure-y stretch things, but you can go online, you see all these great websites. Physical therapists are very community-minded people, and there's a bunch of really good stuff. In fact, there was a research study in one of the medical journals last year where they actually looked at thousands of YouTube videos posted, and if licensed people post the thing for the stretch or the exercise, it's fairly accurate. And it's much easier to look at a video of someone doing a stretch or an exercise and understand it than to look at a kind of printed move your legs here and stuff. It doesn't work as well.
Yeah, so the technology is going to result in many more positive outcomes.
Yeah, I think so, and it's good to know that you guys are doing some stuff on that at the Hebrew Home. So back to our topic, we mentioned a few of them. So clearly, a hip fracture, joint replacement. What are some of the other reasons that people come for subacute?
There are occasions where an older adult is living alone in the community and perhaps their children are located across the country. And maybe they're not eating as regularly as they should, or their blood sugar isn't as stable as it can be, and they have they pass out in the kitchen and they end up going to the hospital. So an individual who has had some challenges with their diabetes or their heart, they may come into a subacute facility to get stronger so that they can return home. In addition, someone who, for example, if I have a major stroke and I'm in the acute care hospital, I can go from there to an inpatient rehabilitation hospital, have intensive 3 hours of therapy a day for a few weeks of time, and I'm still needing additional help and work. So then you would come to a skilled nursing facility for subacute care, and you would receive, again, 5 to 6 days of therapy a week. We would continue to work on helping you to achieve your highest level of independence and work with your caregivers and families to prepare you to go home. And that can include doing a home assessment where we're looking, do you need a ramp because you're now going to be living your life in a wheelchair, or do you need a brace for your leg because you can't keep your knee straight? And then once you do go home, we would refer you to a home health care agency to continue your therapy in the home environment. So someone with a neurological problem, whether it was a fall with a head injury or a motor vehicle crash, if you have Parkinson's disease, if you have multiple sclerosis, other neurological conditions, subacute services would also be beneficial to you.
Right, that's important to know. So people with certain chronic conditions, because of the nature of that disease, are entitled to maybe more services, given in certain contexts.
Correct. And progressive neurological disorders such as Parkinson's disease or other neuromuscular diseases, you can have exacerbations where your symptoms are worse and then remissions where they're better. And based on that cycle of illness, you will qualify or requalify for therapy over time.
Okay. All right, well, let's go to the phones, Mary Fran, and we're going to speak to Adam. He's calling from New Jersey. Adam, welcome to the Healthy Aging Show.
Hey, how you guys doing?
Great.
Good. I had a quick question. I'm not sure if this is relevant to the discussion you're having.
Okay.
But I'm going to ask a question and then get off the phone because I'm driving. But anyway, I'm an ER provider, and a lot of times we have these patients, and I'll give you an example where, we have someone with dementia and they live alone at home, and it's like their fifth time falling at home. And, they're obviously apparently not safe for discharge from the emergency department. But at the same time, we do a large workup and we don't really find an acute medical issue to admit them to the hospital. And we get a little resistance from the hospital's team to admit them. And I was wondering what Medicare rules are with somebody that obviously needs physical therapy and is unsafe for discharge, but needs admission to the hospital. I was wondering if you guys maybe comment on that a little bit.
So Adam, this is a tricky subject because of what we said before. So it's a 3-night rule for Medicare, and then separate from that, of course, you have Medicare telling you in the emergency department you need a good reason to admit them to the hospital. So in the case of fall with either no or a minor injury, right? What I call it is it's like you're ready to watch the bus accident happen. Right, the buses are going to collide, and you know it's going to happen. So you once the patient fractures their hip, you're good to admit to the hospital, but not the week before after the fifth fall, right? So it's a real conundrum, and I think from a perspective of a provider, primary care doc, the trick to me is, well, are they unsafe at home? And what services could you put in place to prevent them from falling? Mary Fran will talk a little bit about that. But what I'll do is separate, Adam, and I know you're going to get off the phone, which I think is safe, but for our listeners and you. So you got to separate out what's needed and who pays for it. So just because you have Medicare or an insurance program doesn't mean they pay for it. As an example, Medicare doesn't pay for your food. They don't send food, and if you're starving, they will not pay for your food unless you're in the hospital. So you might need an aide. They won't pay for that. They will pay for a walker. So Mary Fran?
Mm-hmm. In the home environment, it's important, based on the question just asked, to connect with a home health agency who will send a registered nurse into the home to assess the safety, because you just described an individual with cognitive impairment or dementia who's fallen 5 times and has presented to the ED emergency department 5 times. So it's very valid to get a home health agency into that environment to make a determination. Again, it has a lot to do with resource availability. As was just stated, there is a care management group. There are case managers who can also assist individuals, but again, it's on a private pay basis. There is no insurance that I'm aware of that currently pays for that.
And on the ground, what really happens is that because the topics are complicated and because most people don't have direct experience, fortunately, at this time, although given the demographics, more and more people are getting this experience, they don't agree. They want the policy to be more inclusive. So, they get the fact, okay, so mom needs a walker, so Medicare will pay for that. So, okay, that's all good. So they agree with that policy, but Medicare doesn't pay for a home health aide to observe a patient with cognitive impairment who lives in an apartment that maybe is poorly lit or has some kind of wires and rugs and stuff. They will pay for the nurse to go in with a physical therapist to assess the home and say, yeah, there's a problem, that's a problem, you need a grab bar in the bathroom, and sometimes that works, but often it doesn't. And then as a physician, I get in the middle of this because, the fact sometimes there are resources, but the family, the patient typically, and sometimes the family, don't want to use the resources, meaning the money in the bank, to pay for the services that the person needs. And they got to, we talked about confronting the reality a couple of minutes ago, Mary Fran. The reality is that, you have to use your funds to pay for this kind of stuff.
And it is a great challenge for individuals with mild cognitive impairment who are living on their own at home and, as was just described, maybe had multiple incidents of falls. But no insurance company will pay for 24-hour supervision that I'm aware of.
Well, unless you have insurance for that.
Correct. But it's a very difficult situation to be in.
Right. And that I think, to me, that's the crux of the problem. That's why it's really great, Mary Fran, that you were able to come on, because people just don't understand this. Because why should they? This is the world we live in. And in fact, as you know, many times the physicians don't understand this. That's why we have, on the hospital side, we have care managers now, and of course the social workers who help us with aspects of this, not only explain to the family, but to the staff that's available.
And we also, in the skilled nursing facility, have specialists who are discharge planners who assist the patient and or their family or their caregivers in establishing a safe discharge plan.
All right. Well, Mary Fran, thank you so much for coming on. This has been a really instructive conversation for our listeners and for me. Adam, thanks for calling. And to our listeners, we're going to now switch gears. We're going to say goodbye to Mary Fran. We're going to have Jennifer Flood come in after the break, and we're going to talk about nutrition and obesity.